Hello. Today I'm going to be talking to you guys about elbow subluxations and dislocations. There are three major bones in the elbow. That's the humerus, the radius, which is lateral, and the ulna, which is medial. We're going to focus on two of the major ligaments within the elbow. They both have multiple sections, but the ligaments are the ulnar collateral ligament, and then you have your radial collateral ligament. Mechanisms of injury for subluxation and dislocation are very much the same. Direct blow to the elbow, foosh, and hyperextension. Signs and symptoms are swelling, ecchymosis, pain, decreased range of motion, and decreased strength. A way to test for dislocation is by using x-rays, because any sort of like manual test will definitely cause pain, and it can actually worsen the injury. So it's better to send them to get x-rays and make sure it is what it is to determine dislocation. Subluxation, you would probably have to get an MRI, honestly, because that'll probably mess up some of the ligaments in the elbow if it came out and goes back on its own. Some predisposing factors for this are overuse, just minimal protective equipment, and then repetitive activity. Some other injuries that are confused with subluxation and dislocation are fracture, epicondylitis, bursitis, and bicep tendon rupture, and then you have your nursemaid's elbow. So when you have a elbow dislocation, you don't want to immediately reduce it as an athletic trainer. You would then send them on to an orthopedic surgeon and have them do that. But ways that we can take care of it, just make sure they police, mobilize it, NSAIDs, and strengthen the muscles surrounding the elbow. Some prevention for this are using braces, taping, and just strengthening all of the muscles in that region. Here's my peak hot. And now I'm going to talk to you guys about posterolateral rotatory instability. So posterolateral instability is caused by the persistent efficiency of the lateral collateral ligament complex, um, aka the lateral ulnar collateral ligament. Um, this is caused by the proximal radius and ulna like externally rotating together with the humerus, causing a posterior subluxation or dislocation of the radial head. There are three different types. We don't typically see this, but I feel like the main one you would come across is the first one, and that's like the least complex. But type 2 and 3 are more serious damage because it's kind of like all of them combined. Some signs and symptoms of this are lateral elbow pain, clicking, locking, and snapping. Um, Mechanisms of injury are foosh. I want to emphasize the valgus movement with the forearm and supination with axial loading. Some predisposing factors for this are previous subluxation, previous dislocation, or just previous elbow injuries in general. And then you have dysplasia or hypoplasia of the cord. There are quite a few special tests, but I'm only going to show the ones that I found to be useful. So the first one is the lateral pivot shift apprehension test.
Constantly cleaning up. Pet hair is exhausting. So get your paws on a Swiffer Sweeper. Sweeper makes cleaning easy. The heavy-duty dry cloths pick up crazy amounts of hair. Stop cleaning. Start Swiffering.
In this video, I'm going to talk about the lateral pivot shift test or apprehension test for posterolateral rotatory instability of the elbow.
Get our very own assessment ebook and mobile app. Links are in the video description.
Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outstretched arm, generating an axial load, valgus force, and an external rotation movement about the forearm with respect to the humerus. This causes the radial head and proximal ulna to subluxate posterolaterally away from the humerus in a rotatory fashion, detaching or tearing the lateral collateral ligament complex in stage 1. In a more severe stage 2, the tissue disruption progresses anteriorly and posteriorly around the elbow to the medial side, and in stage 3, the injury involves the medial collateral ligament or even the common flexor pronator origin as well. Regan et al. In the year 2006 have found a sensitivity of 100% for the anesthetized patient with the lateral pivot shift test with an unknown specificity, and a sensitivity of 37.5 for the awake patient in the apprehension test with an unknown specificity as well. For this reason, we give this test a questionable clinical value in practice. The execution of the lateral pivot shift test in the elbow is similar to the performance of the lateral pivot shift test in the knee. To perform the test, have your patient in supine-lying position with the arm overhead and the examiner standing at the head of the table. Start with the elbow in full extension and gently bring the forearm into supination by rotating the patient's wrist. While slowly flexing the elbow, the supination torque is progressively increased, while a valgus torque at the elbow and an axial load along the forearm are added. Maximum subluxation usually occurs around 40 degrees of flexion, at which time the supination is reduced and only a pure valgus torque is maintained. This test is positive if a subluxation of the radial head is witnessed by a prominent bump on the posterolateral elbow and dimpling of the skin behind the radial head that occurs as the posterolateral capsule is pulled into the joint. With further flexion, the elbow reduces with a visible and palpable clunk. It is important to relax the supination torque for reduction to occur without damaging the elbow. As this test is usually impossible to perform in the awake patient, the test is rather positive if your patient experiences apprehension during the movement. The patient may verbalize that the joint felt as though it was about to dislocate, but an actual dislocation or subluxation does not occur. This test variation is called the lateral pivot shift apprehension test. Alright, this was our video on
And now I'm going to show you the posterior rotary drawer test.
video. I'm going to talk about the posterolateral drawer test for posterolateral rotatory instability of the elbow.
Get our very own assessment ebook and mobile app. Links are in the video description.
Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outstretched arm, generating an axial load, valgus force, and an external rotation movement about the forearm with respect to the humerus. This causes the radial head and proximal ulna to subluxate posterolaterally away from the humerus in a rotatory fashion, detaching or tearing the lateral collateral ligament complex in stage 1. In a more severe stage 2, the tissue disruption progresses anteriorly and posteriorly around the elbow to the medial side, and in stage 3, the injury involves the medial collateral ligament or even the common flexor pronator origin as well. Although Kamp et al. In the year 2017 described the posterolateral drawer test as the primary examination method and the most reliable and sensitive test for posterolateral rotatory instability, reliability and accuracy studies are lacking. For this reason, we are giving this test a questionable clinical value. To perform the test, have your patient in supine-lying position with the arm overhead and the examiner standing at the head of the table. The hand and wrist of the patient are fixated between the examiner's upper arm and body, leaving the forearm in neutral rotation. For the left elbow, fixate the humerus on its most distal part with your left hand, with the thumb on the posterior surface over the triceps tendon. Grasp the forearm with your right hand, with the index and middle fingers along the anterior aspect of the proximal radius and the thumb on the subcutaneous border of the ulna. The patient needs to be relaxed for this maneuver, which is why a good explanation of the maneuver to the patient is crucial. To help the relaxation, various random pain-free movements can be made first that minimally stress the elbow. When the patient is relaxed, apply a posterolaterally rotatory force to the proximal radius with the fingertips of the right hand while holding the humerus stationary with the other hand. Subluxation is usually maximal between 20 to 40 degrees of flexion, but the test is repeated at various angles from 0 to 90 degrees to determine the location of maximal instability. This test is positive by a visible posterior subluxation of the radial head and dimpling of the skin between the radial head and the capitellum. A clunk sound can be a confirmatory finding which indicates reduction of the radial head after subluxation. If the patient is able to relax adequately, a slight valgus force can be applied during the test to amplify the degree of subluxation. A positive test at a higher flexion angle around 80 to 90 degrees is indicative of marked laxity of the posterolateral capsule and not just the LCL.
And then the last test I'm going to show you guys is the stand-up test.
In this video, I'm going to talk about the stand-up test or chair push-up test for posterolateral rotatory instability of the elbow.
Get our very own assessment ebook and mobile app. Links are in the video description.
Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outside laterally, posteriorly around the called chair valgus torque at the elbow, resulting in posterolateral subluxation of the reason we give this test a questionable clinical value in practice. The stand-up test makes use of the patient's body weight to create an axial load and valgus torque at the elbow, resulting in posterolateral subluxation of the elbow. In order to perform the test, have your patient seated on a chair with armrests. His elbows are both in 90 degrees of flexion with abducted shoulders and the forearms supinated. Then ask your patient to push himself up from the chair. This test is positive if the patient has apprehension, reports a sense of instability or lateral elbow pain, or if actual dislocation of the radial head takes place.